Good evening, everybody. We are so excited that you're joining us this evening for the Myasthenia Gravis Association's Vaccines and NG webinar with Dr. Howard. A couple of housekeeping notes before we get started. We are going to take questions in the Q&A today, and Dr. Howard will look at them after he is done with his presentation and discuss. And then secondly, just want to say thank you to Alexion for their sponsorship of our program today. Also following our program, you're going to get a survey in the email and in your email, and we'd love your feedback. And it also will have upcoming opportunities for you to connect with us. So I am joined today on Zoom by our team at the NGA. We've got Catherine Clemens, McKenna Fulton, and Hallie Walker. And we have our big star of our presentation, Dr. James Howard. He has been in the neuromuscular space for over 45 years at the University of North Carolina at Chapel Hill. Dr. Howard is a well-loved and cherished key opinion leader in our field, and we really appreciate that he's taking time today to discuss with us this very important topic. Dr. Howard, I'll let you take it away.
Thanks, Allison, and good day to everybody, and thank you for joining with us. We're going to talk about vaccines and myasthenia, first in a general fashion, and then we'll get a little bit more specific. I can't. There we go. So first is that the comments and the opinions that I speak about today are mine and mine alone, and they don't necessarily reflect any opinions from the University of North Carolina, nor the Myasthenia Gravis Association. So these are my requisite disclosures. I receive research support, predominantly clinical trials, but other things as well from a number of organizations, pharma, foundations. I consult for a broad range of industry partners who have interest in myasthenia, and my primary role in that regard is guiding them in the development of new drugs that they want to try to bring to market. This will be fairly or unbiased. We'll speak about selective drugs, some of which are approved and some that are not, and I'll highlight that for you. But I have no particular investment in any company in a singular fashion. So what's the state of the union? And I think this slide tells it all. Tremendous amounts of confusion, tremendous amounts of misinformation and truth that's scattered through there. And the problem is, how do we dissect out and understand what we should believe in and what we should discard? And I hope that I can give you some insight into that. And this is problematic not only for you, but it's becoming problematic for us in the healthcare field. And so we have to be careful and do our due diligence as well. So tonight, I hope that I can get you to have some further understanding as to what really is a vaccine. When should I get my vaccines? We'll speak a little bit about vaccine safety. We can't go into super depth because there's so many different kinds of vaccines out there. And then there's some changing thought patterns from a clinician perspective, a neurological perspective of what vaccines people should have and when they should get them. And then we'll speak about vaccines as they pertain to myasthenia alone. So a vaccine is a biological preparation, and it's designed to protect you or provide immune safety against a particular disease. how it's made, and we'll talk about the different kinds here in the next slide or so, that it contains either a weakened or killed organism, fragments of that organism, or genetic material that codes for the particular recognition of that pathogenic organism, whether it's a virus, whether it's a bacteria, etc. And it's designed to stimulate our immune system to recognize that what it's encountering, we as the host, if you will, is not us, that it's a foreign invader, and that we can deal with it without causing a disease. And so it's a pretty tall bar that we're trying to achieve. And there are so many different kinds of organisms, bacterial, viral, etc., fungal, in fact, that it's a lot of work to develop a vaccine to target selective organisms or pathogens, if you will. Regrettably, we don't have a vaccine that covers everything, and hence the need as we treat our patients for multiple vaccinations. And so vaccines work by several mechanisms. One, they can mimic an infection at a very low grade that trains the immune system to recognize, to be able to mount an attack. Vaccines, when we administer them, trigger the formation of antibodies. And we're all well aware of antibodies because they're the pathogenic role in myasthenia. And so these are proteins that target specific proteins, if you will, recognition sites, if you will, in myasthenia on the acetylcholine receptor, in a bacteria on the surface of the bacteria, same for the virus and its capsule, what we call the capsid of the virus, and thereby negate its activity. And then it enables what we call immune memory. And so they reside, we have cells that are formed in our immune system that are actually coded and retain this memory to re-recognize the pathogen, the bacterium, the virus, if you will, should it ever come back and we're exposed to it again. And as we'll see that some vaccines are excellent in doing that job, and they can provide us lifelong immunity, and then others only temporary immunity over a short period of time, whether it be months, 1 or 2 years, and we have to sort of reprogram the system, if you will, in order to continue that safety. So there are a number of different vaccine types. There are those that are live vaccines, as we call them. They've been what's called attenuated. They've been dampened in their aggressiveness, if you will. And the example of that is the measles vaccine that we use. We have inactivated vaccines, and these are, we take typically a virus, and polio is the prime example. The polio virus is rendered inert, so it can't do its dirty deed anymore. And by administering it, we can then downregulate and prevent polio infection. We can take parts of a virus, a subunit, if you will. And this is how we deal with hepatitis B, for instance, and immunize you with that subunit. It then recognizes a critical portion of the hepatitis B virus and then prevents its proliferation. We also can use toxins, and we activate toxins. Tetanus is an infection that is overwhelmingly aggressive and deadly. And by that, tetanus lives in the soil. It's ubiquitous in the soil. And in certain instances, through an open wound or something, we can become infected with the tetanus. And then its toxin is highly aggressive. And by inactivating the toxin, we can sort of turn it against itself so it can't do what it's supposed to do. And then we can alter the genetic code of viruses or parts of a virus, very small pieces of a virus that play the predominant role in an infection. And this is how we're dealing with much of the COVID infection, the COVID virus that we're dealing with. We alter what's called messenger RNA, and mRNA is new technology that has been developed. It's been in existence for several decades, and it's now coming to use in part as a vaccine, where we can stimulate the messenger RNA to produce proteins that recognize a particular component, what we call the spike component of the COVID virus, where it latches to a cell and infects the cell by recognizing it and rendering it inert. Messenger RNA is also being used in a number of other programs that are therapeutic. We're developing ways to use this to provide treatments. And in myasthenia gravis was one of the classic examples where we're using a form of messenger RNA to target selective B cells, cells of our immune system, to shut them down to prevent antibody formation. It's been done in tumors as well, where we can target a specific tumor, usually at this point in time, a melanoma, and turn it off and produce long-lasting improvements in either tumor suppression or in the treatment of myasthenia gravis. That's a very active area of clinical research at this point in time. Vaccines are important because they prevent serious illness, they prevent outbreaks of the illness. We use it to protect vulnerable populations, children, adults with certain disorders that if they were infected, say, with a virus that produces a bad respiratory infection like RSV or flu, we prevent it from happening. And then it's been used worldwide to eradicate disease. And polio, for instance, when I was a young kid, several of my neighbors developed polio. And some of them quite severely. They were in ventilators. At that point in time, we were using something called the iron lung, which is a big long tube, and you're in it except for your neck and your head. And by sucking pressure in and out, that's how you breathed. And people spent months, years in iron lungs. And polio vaccine essentially has eradicated that disease from the face of the earth. Regrettably, it's starting to have a comeback in certain parts of the world and has now been reported here in the United States because those individuals have not been vaccinated and been exposed to the virus. So in one aspect, we can prevent disease. In another aspect, we can lessen the severity of the disease. And the prime example of that is COVID. Why do we vaccinate folks to prevent COVID infection? We can't prevent it in many instances. Sometimes we can, but the key is with vaccination, we can keep you out of the hospital and we can keep you alive. And there's excellent research that has been done looking at populations who did not get vaccinated with COVID compared to those who did. And those who were vaccinated, in the overwhelming majority, did better and had better outcomes than those that did not. And in the myasthenia space, when COVID was at its peak in the early parts of the pandemic, we began tracking patients with myasthenia. And myasthenic patients who got COVID did worse than those who did not have myasthenia. And when they were vaccinated, many of them were able to stay out of the hospital or had short hospital stays. But most importantly, you continued to live. So there's been a lot of talk lately about vaccine safety. Everywhere you pick up a newspaper, a magazine, or see something on the internet, there's a lot of information about the lack of vaccine safety. And that's just not true. It's one of the misinformations that's being sent out there. Vaccines are thoroughly tested. And even after a vaccine is approved for use, it's continuously monitored. Yes, adverse events occur. There's nothing free in this world. And in some cases, those adverse events are severe, much like anything that we do or take. Driving automobiles without a seat belt in an automobile crash, high probability of severe injury or death. With a seat belt, you're much safer, but you still may be severely injured and you may die as the result of that motor vehicle accident. And so anything that we do has its issues, and the use of vaccine has lessened the risk, if you will. Vaccine side effects are typically mild and temporary, usually related to the injection site with pain, discomfort, that stiffness of the muscle that will come an hour, 2 hours after the injection and will last 24, sometimes 48 hours. On occasion, more serious side effects do occur, but they're rare when we start looking at the actual numbers compared to the numbers of individuals who've received the vaccine. There is some discussion out there that vaccines cause autoimmune disorders. In my estimation, this is overblown. Guillain-Barré syndrome has been reported following influenza in COVID-19 infections. The virus infection itself, that is often a trigger for the Guillain-Barré syndrome, is much more likely to cause Guillain-Barré. In all of this, these instances are extremely rare. There's a report out there that vaccination for COVID-19 caused what we call CIDP. It's an inflammatory neuropathy. It's had some press because it's been shown that our FcRn inhibitors, such as efgartigimod, I would assume nipocalimab and rozanolixizumab would work the same, is very effective in treating these. But there's only one case of it in the entire world. And it's an individual who already had a neuropathy that was a genetically acquired neuropathy. A number of autoimmune inflammatory syndromes have been reported because of, quote, aluminal. It's controversial. It's not widely accepted in mainstream based on the literature and the science and the research that has been done. ITP has been reported to occur with mumps, measles, and rubella, as well as COVID vaccinations. Yes, very rare. It's usually mild and it goes away. Some people have argued that diabetes and multiple sclerosis will occur. And there's no relationship that's been found. Looking at large studies, accumulated cases of vaccination in these reported instances across the world. So I want to assure you that vaccination itself is not at high risk to do these sorts of things. Where do we turn for guidance? Critically important. Who can you trust? And I think it behooves you that everyone has to do due diligence. When you're doing research, is this appropriate for me? Look at more than one source of information. It used to be that the Centers for Disease Control and Prevention were our go-to place. I'm not sure we can say that anymore. And so I've only given it 2 stars. I think there are changes going on at the CDC, and information is being taken down or altered So now I'm not sure we can fully trust at this point in time what it says. But don't not look at it. Look at it and then compare it to what the American Medical Association says, what the American Academy of Pediatrics says. The Children's Hospital in Philadelphia is a vaccine education center. That's excellent. And then there's an interesting place at the University of Minnesota. It's called the Center for Infectious Disease Research and Policy, CIDRAP. And we'll speak about it a little bit more. That is starting to gain more knowledge, or people are becoming more aware of it, that I think is highly reputable. And I'll show you why. Social media is not a good place to get your information from. Yes, there's good information out there on social media, but there's also a lot of bad information out there. It becomes very difficult to try and sort out which is which. So when you're doing your own vaccine research, do not rely on Facebook, on Instagram, sources like that, because I don't think it's very trustable in the whole scheme of things. So CIDRAP is becoming more prominent, as I said, in part because of the change in federal guidance and the question that people are now asking, who can we trust? It's supported from an unrestricted grant from Christy Walton, who's a well-noted philanthropist. She donates her millions of dollars. It takes feedback from about 60 different organizations, from combing the scientific literature, and its goal is to safeguard vaccine use in the U.S., but elsewhere, because it's looking at the best available science. It's not being influenced by pharma. It's not being influenced by government. And it's looking at ways to safely optimize the protection of individuals, their families, and their communities. It doesn't tell you what to get vaccinated with, or which is the best for you, or whether you should or should not. Rather, it's evaluating the information out there and then sharing it. So it's a resource that you could consider using. We know from science, and this is an early report from CIDRAP, that vaccine or vaccination is protective against COVID hospitalization. We know from CIDRAP that vaccination is protective against RSV infection. And they feel that the risk of Guillain-Barré after a particular vaccine is less than 1 in 30,000 individuals vaccinated. Their data says that seasonal influenza vaccine is effective at preventing influenza or flu. And there has been some data out there that says to use standard dose, to use high dose in certain populations, and they don't have enough information to draw specific conclusions. They didn't tell you you had to get it. They just told you this is the data that we have. So let's look at some of the treatments that we use in myasthenia. And what does their use have on vaccination? Because I think that becomes important. We know that steroids have multiple effects on the immune system, and those effects may impact vaccine response. It inhibits T cells, one of the lymphocytes, one of the cells that are involved in immune function. It reduces the production of what we call cytokines, which are chemicals that are released that are necessary to fight infection. How much, to what degree, varies from individual to individual. And so the response to vaccines may be, not is, always, but may be diminished. Live vaccines are contraindicated. So any time you go to get a vaccine, you need to know, is this a live vaccine? Is this an attenuated vaccine? Is this a recombinant vaccine? Live vaccines should not be taken by patients with myasthenia gravis if they're on any form of immune suppression. Absolutely not. You're asking for trouble because there's the possibility that the virus that is in the live vaccine could actually flourish and make you much sicker. We have data to suggest the relationship between when steroids should be used and when you can get a non-live vaccine. And we think about a week, 3 to 5 days is reasonable. There's data to suggest that after you receive a non-live vaccine, can you start your steroids? And people say about 2 weeks. And this is based on studies that have been done. And then if you discontinue steroids, when can you get a live vaccine? And we think about a month. What about when we look at our non-steroidal immune suppressants, azathioprine, mycophenolate? I will put in this category. We know that mycophenolate suppresses antibody formation, and it may inhibit the ability for cells to be recruited to deal with the inflammatory process. Much of this work has come out of the transplant world, where they have shown that mycophenolate, rather than other drugs, is sort of the one that's going to cause them more problems. Again, live vaccines should not be taken if you're on one of these drugs. And I blanketly said, as I just did a minute ago, anyone on an immune suppressant who has myasthenia should never take a live vaccine. And so vaccinations may be less effective if you're on mycophenolate. Other immune suppressants like azathioprine, when can we use them in relationship? With azathioprine, we don't think there's any delay. With CellCept, mycophenolate, 5 weeks. From a non-live vaccine to resuming your immune suppression, no delay with azathioprine. We don't have data for mycophenolate. And then between the two, going to a live vaccine, about a month. Now, sometimes this is not practical. And so this is a decision you, in concert with your treating physician, have to make. If one's myasthenia is not well controlled at the time, we may not want to take these delays. We may want to say the risk of my myasthenia is greater than the risk of having a problem in terms of mounting a vaccine response. And so we would start earlier. But that's an individual decision between the treating physician in concert with you. Plasma exchange removes immune function cells or proteins out of the circulation. And as such, we disturb the role of the cellular components of our immune function to a degree. IVIG inhibits a variety of immune cells in terms of their ability to function, therefore T cells and B cells. We think that IVIG may dampen the immune response to measles, mumps, rubella vaccine that may last for several months here. Don't have data on other vaccines. It's not been studied well. But in general, we would say that if we're using a non-live vaccine, plasma exchange, there should be no interval. And after taking a vaccine to restart plasma exchange and IVIG, we don't think you need to wait. Between the two, in taking a vaccine, we don't believe you need to wait. Do it. When we look at the neonatal FC blockers, efgartigimod, nipocalimab, rozanolixizumab, and others, these are the ones that have been approved for use. There are others that are coming, but they will all function the same. They reduce the level of IgG in the bloodstream, and that's the mechanism by which they help autoimmune disease. We don't know the full story on live or attenuated vaccines and the response to them in the presence of an FcRn inhibitor. Again, live vaccines are not recommended during treatment with FcRn blockers. We do have some data with efgartigimod And we know that there was transient reduction in the immune response to flu vaccines in people who got vaccines. That's shown here. We know that the bounce back is very good. And so here's your IgG level. Here's a treatment with FcRn, and you can substitute rozanolixizumab, etc. It doesn't matter. We're going to see the drop in IgG. It's going to come back. We retreat you. It drops. It's going to come back. And here we did it 3 times rather than 2, and you can see the pattern. And so by reducing this, are we going to significantly inhibit our ability to generate vaccine responses? It would be suggested over here only occasionally would we see us fall below protective levels of vaccine suppression. And so even though we are dropping IgG levels here fairly drastically, but they do come back fairly quickly, we can maintain for the most part the level of vaccine safety, if you will, during this time. And here's where we vaccinated the patient. And one sees that the IgG level drops and comes back. We vaccinated on the return, and we can maintain protective titers. If we vaccinate in between, probably the best time to do it, we transiently reduce levels, but they will come back over time. And this is just more data to show that when we vaccinate here, we can maintain whether we're doing it in the treatment-free period, whether we're doing it in the middle of treatment cycles, as shown by these arrows. Despite the fact that we reduce IgG levels, we can still maintain responses to flu and other vaccines that were administered to individuals during this time. So what about B-cell depleters? For those of you who've had rituximab, for those of you who've been treated during the trial, the MINT trial with inebilizumab, they affect B cells, the antibody-producing cells, through a mechanism called antibody-dependent cytotoxicity. And so vaccinating, again, with live vaccines, attenuated vaccines, is not recommended at all during treatment with these, if you're myasthenic or any disease, if you will. But we know that using these, one needs to wait a considerable period of time before we reconstitute our cells enough to be able to deal with an infection and a vaccine response. After a non-live vaccine and then administered and then resuming B-cell depleters, it's about 2 to 4 weeks, almost a month. And then if you stop a B-cell depleter, when can you take a vaccine? Really, when your B cells come back. And so this one carries with it a little more risk, but as I said earlier, each individual situation is distinct, and whether or not you take the risk and get vaccinated, and it may not be overly effective, could be, but it may not be, that's a decision between you and your treating physician. What about with complement inhibitors? There's no apparent impact with those that are approved, eculizumab, ravulizumab, zilucoplan, because the vaccine is inhibiting a downstream part, what we call the terminal complement pathway. And I'll show you a slide of what I mean. There is a vaccine that is mandatory if you take this class of drugs. You must be vaccinated against Neisseria meningitidis according to the current guidelines. And you need to be vaccinated at least 2 weeks prior to receiving your first dose. We'll talk more about this in a minute. But why do I need to be vaccinated? No, all my other drugs, I don't need to. Why is this one so important? And so here's myasthenia on the left. And you should be able to see my light pointer here. Here's your acetylcholine receptor. Our antibody binds to it, and that's producing the myasthenia. Myasthenia antibodies also activate what we call the complement system, the terminal complement system, which is a series of proteins, and they're numbered in the manner in which they were identified. And we're interested in protein 5, 6, 7, 8, and 9, because that conglomeration forms this pore-like structure. We call this in the old days the membrane attack complex. We now call it the terminal complement complex. And it's important because it binds to the muscle, and then it drills a hole through the muscle. The muscle leaks its content and then destroys the neuromuscular junction. And by using complement inhibitors, which block this region, we prevent this formation. And that's why patients who take complement inhibitors get stronger. The bacteria, Neisseria meningitidis, works in a very similar function. It works by attaching to the cells, but by blocking this membrane attack complex, we now increase the risk of one's ability to be infected. And so our therapy, while beneficial here, blocks what destroys the organism here and increases the risk for infection. So this is the reason why one must be vaccinated, because we don't have the natural defense mechanism that's available to treat this, or for the body to treat this infection. So what about this meningococcal infection? And so this is data from the disease surveillance system from 1996 to 2024. And one sees that the actual rates of meningococcal infection have been slowly falling over time. It used to be about 1.2 per 100,000 people. And then in 2005, we had a vaccine called Menactra. Then 5 years later, Menveo, and then several others have come more recently. We now have a vaccine called Bexsero, and these target different strains of the organism. Menactra targets 4, Bexsero targets 1, the B serotype. And now the rate has gone from 1.2 to 0.1 per 100,000 population. Meningococcal vaccination has been very common. All of our students who go to college have to be vaccinated. Some high schools, some grade schools mandate that one has to be vaccinated before they can attend school. These rules are now being challenged and done away with in certain states. And it remains to be seen the problems that we're going to encounter because of that. This is the rates of infection with the use of eculizumab. This was the first complement inhibitor approved back in 2017. And one sees here in light blue the use of this drug in treating patients for a number of reasons, more than just myasthenia. But one sees the vaccination recommendations initially with the quadrivalent. Menactra was the first one we started. And then when Bexsero came out, we started vaccinating against the B serotype. And we can see that the rates have steadily fallen over time substantially. And so we talk about events per 100 patient years. And this says if you take a patient and follow them for 100 years, the risk is you need 0.12. So if you had 1,000 patients, 1.2 of them would be infected. And the light blue line is mortality. And this is with ravulizumab, Ultomiris. This is the latest a complement inhibitor that is approved for IV use. Zilucoplan was the last one that's approved. I do not have any information this with Zilucoplan. And here's the use of ravulizumab over time. And then here are the infection rates from meningococcus here and the mortality rates. It's exceptionally low. We all worry about this. It's critically important, but in reality, the risk is very, very low. But that's to say you still need to be vaccinated. So late 2024, the FDA changed the guidelines for vaccination and was accepted by a subcommittee of the CDC called ACIP. And that was that we had to have complete vaccination, or if one had been vaccinated previously, they had to have an updated vaccination at least 2 weeks prior before we started treating with complement inhibitors. And there are caveats, and we'll speak about that. In the past, we vaccinated with the first dose of each, waited 2 weeks, and then started treatment. And I will show you in the next slide that that timeline has now been expanded significantly before we can use the vaccine. They also said that if the risk of delaying treatment outweigh the risk of developing meningococcal disease, you need to treat and vaccinate simultaneously, but don't wait for complete vaccination. However, you have to be treated with an antibiotic. And so the question now comes, do we have to use antibiotics if we want to use this? In some countries, England, for instance, if you're on a complement inhibitor, you take an antibiotic for life, or as long as you're on the complement inhibitor. In France, that was the rule, and then they changed it and no longer is. In Australia, you don't need to take antibiotics. They simply vaccinate. Their initial dose, wait 2 weeks, and begin treating. And so the rules are different around the world. And it reflects the best understanding of the data and what their health ministries and regulatory authorities feel is the best for their communities that they serve. Questions have been raised, can I get both vaccines at the same time, the quadrivalent and the B serotype? Yes, they can be administered at the same visit, but use different injection sites. So we use different arms, and it's not an issue there. Here is the current guidelines that we're dealing with right now. And so there are two quadrivalents, Menveo and Medquadfi. There used to be a third called Menoctra. It's no longer available. And so here's day 1 of dosing. And at month 2, we dose again. They have to be about 8 weeks apart, at least 8 weeks apart. And then they don't have to be redosed until 5 years. The B serotype, Bexsero, dose 1, dose 2, around 8 weeks later, and then a third dose at 6 months. And this has become problematic, and we'll talk about it. The other is to use the same for the quadrivalent. This is the same as this, but there's another one, B serotype, called Trememba. And there it's 3 doses, dose 1, 8 weeks, dose 2, 6 months later, dose 3. The important thing to remember is that these two in purple cannot be interchanged. You can't take dose 1 with one and dose 2 with the other one and dose 3, whichever one you want to do. They are not interchangeable. And once you start with one of these, you've got to stick with it. Otherwise, it's not as effective. Now, remember that any vaccination we get does not eliminate the risk for the infection. And that's true primarily with COVID. Lots of people who get COVID vaccinations get COVID. but the COVID is less severe. Most of them stay out of the hospital, and the overwhelming majority do not die. Same with meningococcal vaccines. It does not guarantee you will not get a meningococcal infection. But if you do, it will be much less severe, and the overwhelming majority of individuals will survive this. In addition, we're recognizing that certain parts of the world, there are new strains of the infection that have been identified. They're not currently present in the US, but that's something that's being monitored and to see how this is going to evolve. Now, most recently, a combo vaccine has been developed. It's a 5 vaccine. So here are the original ACWY, were the original quadrivalent 4 strains, and the B serotype has been added to this. It's called Pembrya. It can be used when you're going to get both at the same time, and it's perfectly fine to substitute. And when you're only getting one or the other, then you've got to go back. And one has to remember that it only will work with the Trememba strain or the Trememba vaccination. So if you start with Pembrya, your subsequent doses have to be with a Trememba strain or vaccine. And as I emphasized, the MemB, the B serotype vaccines are not interchangeable. So what are the strategies for a myasthenic patient? In general, patients with MG should not get a live vaccine. In general, we believe all patients should be vaccinated against pneumococcus. And this sometimes gets confused. It only works against what we call Streptococcus pneumonia. It doesn't prevent all pneumonias, only the bacterial infection from this organism. But this one is a severe one. So vaccinating with a pneumococcal vaccine protects only this one, but we believe you should get it. We believe you should be vaccinated against herpes zoster, shingles. Shingrix is not a live vaccine. The older form, Zostavex, should not be used, but Shingrix is not a live vaccine. We believe you should be vaccinated against COVID, and we should believe you should be vaccinated against flu, but do not use the nasal spray vaccine. That's a live vaccine and should not be used. And these are typically administered by your primary care physician. In terms of complement inhibition, we don't have a single answer. And so to me, there are 3 options. You can vaccinate or update at the time we first see you. These are individual discussions. It's shared decision-making between you and your treating neurologist. So when I see you in clinic for the first time, we're going to have a conversation that says, I don't know how your MG is going to do. It may be that you're going to need a complement inhibitor at some point in time. Because of the current recommendations and how we administer these, if I decide to use it and you're not vaccinated, that's potentially a 6-month wait. So one way to deal with it is to vaccinate you now so that it's ready to go. The second option is to wait until we decide to use a complement inhibitor and then vaccinate you. And what the pro is that you may never need a complement inhibitor, therefore you don't need to be vaccinated. The con is that it may delay the start of treatment until you're fully vaccinated. That's 6.5-month wait. So if I say, I think you might benefit from a complement inhibitor, and you say, okay, we vaccinate, but now I got to wait 6.5 months before I can start you on a drug. The third option is a twist on that, and that is to use option 2A, but then start treatment, but then I've got to put you on an antibiotic and cover you for those 6.5 months. And there are pros and cons of long-term use of antibiotics. with GI distress, with developing organisms that then become resistant to the drug that I'm using. Often very elderly people don't tolerate this. And so one has to carefully weigh the pros and cons of each of these decisions, and then you and the physician, shared decision making, make what's best in your own interest. And so to summarize, I think the politicization of healthcare has made rational decision making very difficult, not only for you, but for me as well. Complement inhibition is very efficacious and is very effective in treating AChR-positive myasthenia. But vaccination is a requirement for its use. And then the vaccination paradigms that we use for this, as I just showed you, can be different. And the vaccination paradigms for other viruses are changing as well as our treatment choices evolve. And so the same sort of paradigm holds with if I'm going to use B-cell depleters. Are they a potential use in the treatment of your MG? Do I vaccinate you when I meet you? Or do we wait and then hold off the X number of weeks, 2 to 3 months, before I am allowed to start treating them to provide you with maximum safety? And with that, I'll take questions.
Dr. Howard, it looks like there's several in the chat, and do you want to read through them, or do you want us to read them to you?
Yeah, no, unless you have some that you've already seen and have prioritized.
No, I'll let you take a peek. I think that
Okay.
and that was a fantastic presentation. You covered a lot of ground, and we really appreciated that.
So the first question is, I hope eventually you all get to take on COVID mRNA vaccines. I took 2 Pfizer, took 2 Moderna, last being late November, and MG symptoms following in March. Yes, I know I should have not had all of those shots. Do mRNA, if I'm reading this correctly, do mRNA shots, COVID shots, because that's the only one we're using it for, can it cause myasthenia? No, we don't think it causes myasthenia. We think 2 situations that can occur. One is that you already have myasthenia. It's doing its thing, minor fluctuations, reasonably stable. You get a vaccine, and it need not only be mRNA, it could be any kind of vaccine. Vaccines stimulate the immune system. They produce fever. They activate all sorts of immune components, and that in turn aggravates the myasthenia. And we see this. The other is that you have no symptoms of myasthenia gravis, and you're going about your business, you get your vaccination, and then a week later you start developing weakness or ptosis or double vision, and myasthenia comes out. We believe, and there is some circumstantial evidence that you have subclinical myasthenia. It's been quiet, it hasn't raised its head yet, and this simply pushed you over the edge. I have a patient I saw today in our clinical research unit who said I was perfectly fine, and all of a sudden I got sick. Had no symptoms. I rock climb, I do this, I do that, and out of the clear blue following a vaccination, I've got sick. And so we're talking about it, and I said, do you ever bite the inside of your cheek? And she looked at me quite bizarrely, and she said, well, how do you know? I said, how long has that been going on? She says, that's been going on for about a year. And it's my belief that she had myasthenia a year in advance, and the only manifestation was very subtle facial weakness, so that as she ate food and chewed, she would intermittently bite the inside of her cheek. One of the sort of the subtleties of this disease. Another question is, what about vaccine in POTS? The COVID vaccine seems to exacerbate my POTS symptoms. I've been afraid to get the COVID vaccine since. I'm not a POTS expert, postural orthostatic hypotension, if I think that's what you're talking about. So I can't give you a good answer there. I am not aware of any data in the data that we review in terms of vaccine safety with the vaccines that we use that would account for this. If I understood, is someone only on prednisone taking a co-vaccine, there is no need to stop the prednisone. Theoretically, prednisone can alter immune function, the good and the bad parts of immune function. There is some literature to suggest that the vaccine response may not, and I underscore may, not be as effective transiently if I take a vaccine. Our data would suggest that it is not a huge thing when we looked at individuals who were on prednisone and also getting FcRn inhibitors, because we were looking at the role of FcRn. So patients were on a variety of drugs, some of whom were on prednisone, and we found very adequate mounting of vaccine responses. And so I think it's a decision between you and your treating physician. I think it's based on dose. If you're on very low doses, that risk of impairing vaccine response is much lower than to say you're on 80 or 100 milligrams a day. Should folks with MG stagger getting multiple vaccines, i.e. flu, COVID, and RSV? There's no right or wrong answer here. I think we know that the vaccine, because it activates our immune system, it's associated often with low-grade fever, then it's a potential that you stack them, you will have a potential for a more aggravated myasthenic reaction. I have had patients take all three on the same day and have not had difficulties. So I think I would rely on what has been your response to vaccines in the past. Have you tolerated them in terms of myasthenic perspective? Is your myasthenia stable or unstable at the time of planning this? And if you've not tolerated vaccines well, if you have unstable myasthenia at the moment, I might consider spreading them out rather than getting them all at once. But there is no single right answer or wrong answer. In terms of getting 3 vaccines, RSV, flu, and COVID, what's the best timing strategy? Symptom-free, and I think we've just talked about that. If you take Rituximab, what's your opinion on a timetable of when to get vaccinated from a non-live vaccine? I would try and do it as far away from your Rituximab infusion as possible. So if you're getting Rituximab every 3 months, that's a lot of suppression of B cells. I probably would, if I were definitely getting them, I would shoot right for the middle. So around month 1.5, maybe at the 2-month mark would be the best. My gut feeling is, although individuals are different, we've seen people mount beautiful responses to while taking Rituximab. My gut response is that the vaccine response may not be as great as if you were not on the drug, but I would not stop you from getting the drug. Yes, we spoke just in terms about the vaccine, pneumococcal vaccine, RSV. It's recommended by most neurologists that you get them. What's the connection between biting's one cheek and MG? I have found it over the last 50 years dealing with MG that it's a very subtle sign of weakness around the mouth. and it's just a marker that there's some weakness there. Nothing more than that. It's much like, I ask when you wash your hair, do you rest your elbow where you keep your soap on the side of the shower? You'd be surprised how many people say, yes, I do. Or when you wash your hair, do you do it standing up or do you bend over? And you bend over because you have weakness in your arms and your shoulders. And it's easier to wash your hair if you're bending forward, so you don't have to lift your arms up. These are just little nuances that we pull out from a historical perspective when we talk with patients. Another question is, can I get flu and pneumococcal vaccine at the same time? My understanding is yes, but this is a discussion you should have with your treating physician. So direct questions relating to your own health care, I shouldn't be answering. That's something you and your physician talk about. Does thymectomy status influence any vaccine recommendations? Fascinating question. I don't think it does. We don't have any data that it does. Remember, thymectomy, not for MG, but is often performed in infants who have problems with the great vessels of their heart. In order to get to the heart, they take the thymus gland out. And these kids do wonderfully well for later on in their life. And I know of no literature to suggest that it impairs vaccine responses. Does taking Mestinon affect your advice on vaccines for flu and COVID? Mestinon should have no effect on any relationship to any vaccine for flu or COVID. How far before initiating Rituximab should you get your hepatitis booster? I think that's a discussion between you and your physician. There are some physicians who are very specific in how they want their patients vaccinated. Others refer them off to those who are experts in infectious disease, so have that discussion. Should I get a flu shot during my 4-week off cycle after the 4 weeks of VYVGARD Hydro? We think the best responses are seen at least 2 weeks after your last infusion of an FcRn inhibitor, though we have data that suggests regardless of where you receive your FcRn inhibitor, and we only have data for efgartigimod, the IV form, so VYVGARD. We've not done the study with Hytrulo, but we consider the two the same. You will mount a vaccine response regardless of when. But we feel that 2 weeks after is probably stacking everything in your own favor. I'm taking mycophenolate for my MG, so I might do better going off this medication for 5 weeks prior to getting vaccinated. That's a good question. We don't know the answer. From the transplant world, we know that individuals on mycophenolate do not have the best vaccine responses. I do know that if I discontinue mycophenolate in a patient with MG, if they're going to flare, it's on average going to take 4 to 6 months. So I'm not convinced stopping the drug is going to be of benefit to you, and the management of your myasthenia takes precedent in this regard. So again, a discussion for your treating neurologist. So vaccine triggering MG from subclinical to clinical, how do I reconcile triggering the autoimmune with a vaccine for protection when there's apparent risk of worsening health? There is no litmus test. We have to weigh, if you're subclinical, we don't know you have the disease. So there's always a risk that it's going to get uncovered. And it may persist. It may then become active MG. In some instances, We've had patients who've told us that they've been vaccinated. They felt they had a little weakness. It went away. They didn't think anything about it. In a year and a half later, they come down with full-blown MG. So I think any scenario can occur. I think we deal with what is the best for my personal health at this moment in time when I'm asking a question. And again, a shared decision-making process, the advice of your physician, your own concerns or questions, etc., based on your research, your own personal results of how you've tolerated illness, whatever it is in the past, then come up with the best case scenario. But there is no foolproof regimen. So another question is there a genetic sensitivity to vaccines within a particular family? And this participant here discusses the development of MG and with Musk and a brother with Guillain-Barré, etc. We don't know whether there are genetic predisposition that interlink potential development of autoimmune disease with activation and stimulation of the immune system. To my knowledge, there is no answer to this. There's just no data. The cases that you describe, I believe this would be ultra rare, exceptionally rare. So another question is, if I'm only on Mestinon for MG now, should I take the meningitis vaccine ahead of need? I mean, this is one of the scenarios we discussed. That's one of the options. And this is, again, a conversation one has to have with your treating neurologist and your own personal beliefs, and based on how your disease is doing, where you are in the course of your illness. I will tell you that there are 2 documents in preparation looking at vaccination for meningococcus in preparation. One is a opinion piece by several neurologists that is forthcoming. Another is a task force that was put together about 2.5 years ago. Sean Piddock at the Mayo Clinic, who was involved with the NMOSD trials with complement inhibitors, and myself, and we brought in other neurologists who deal with multiple sclerosis. We brought in infectious disease, immunologists, etc., from around the world, and we're developing a true consensus document that discusses many aspects, and ultimately we'll have some recommendations. We're probably still a year out from finishing this, because this is a really deep dive into all of this. But hopefully we'll have better guidance at that time. How often do you take the pneumonia shot? Every 5 years? I don't have that on the tip of my tongue. Can't answer that. And I'm not familiar with THPSO, operation triggered MG. So total hysterectomy, bilateral cell oophorectomy is a gynecological operation. The question was, could it have triggered MG? The operation is a stressor. I don't think it caused the MG. I think someone may have had some clinical MG, and that was the mechanism by which this became uncovered and then symptomatic. I've seen MG start after an insect bite to the bridge of the nose. I've seen MG start within 48 hours following a rear-end motor vehicle accident. In the case that lives with me as clear as day was a young woman who was a high school senior who broke the state shot put record and in 48 hours was on a ventilator. Now, this woman was a true athlete, had been totally asymptomatic, and heaved, I guess it was 8-pound shot that we use in high school, and broke the state record, and in 48 hours was on a ventilator. the shot put, the act of playing in this track and field event did not cause her MG, but the stress. She was elated. She was just ecstatic. That immune interaction is what caused the issue. So another question, preventive treatment with PCP prophylaxis, pneumocystis carotii, on patients for steroids. Again, that's an individual decision between you and your treating physician. I know many neurologists do not do so. I did not give my patients prophylactic PCP therapy in all the ones that I've treated with steroids over the last 50 years. But the bug may be changing. I think this is a heart-to-heart conversation with your treating doc. The last question we're going to talk about is, are there any close to understanding what causes MG at its root? No, if we did, I'd be famous, and I'm not famous yet, so I don't have an answer.
Dr. Howard, this has been a fantastic presentation. Thank you so much for staying on well past 6 o'clock and getting.
Well, I'm sorry I went over.
No, you answered so many questions, and this was just really great that you were able to take time today to be with us, and we really appreciate it. So thank you to all of you for attending. We would love your feedback on the survey, and we'll see you next time. Thanks again, Dr. Howard.
Well, thanks for the opportunity, Allison. It was great.
Have a good night.
Yep, we'll see you in a few weeks. Bye-bye.
Bye.